Hey, thanks so much, everybody, for joining Georgia MemoryNet Insights today for our webinar. I'm excited to introduce myself today. I'm Ted Johnson. I'm the one of the co-leads for the primary care core, and excited to have you here as we go through a talk about blood-based biomarkers. This is my sixth or seventh year working with Georgia MemoryNet. When I'm not working with Georgia MemoryNet, I'm the chair of Family and Preventive Medicine, one of the faculty development leads in the Division of General Internal Medicine. And pertinent to today, I'm also doing a fellowship in preventive medicine and public health. And so I'm going to bring some of those concepts in today. All right, I'm going to go ahead and share slides, and here we go. All right, with this information, you can get online to get information about how to get CME credit. We're really proud to be partnered with the Morehouse School of Medicine and the area health education centers to make sure that you can get your credit that you deserve for attending sessions such as these. There's more information about how to access the activity homepage. Here's our title for today: Blood-Based Biomarkers for AD Pathology, False Positives, False Negatives, and Why Prevalence Matters. It's kind of a nutty, nerdy sort of math type of treatment of what to do with blood-based biomarkers and what happens when you drastically change the prevalence of the condition in the testing group that you're using. So I have no financial or other relationships to disclose, and there's no ineligible companies that I'm working for here. All right, so here's some learning objectives for today. And so we are going to learn how to interpret blood-based biomarkers for Alzheimer's disease pathology and apply principles of sensitivity and specificity, positive and negative predictive values to some real-world clinical scenarios. We're going to compare our present early blood-based biomarkers information to maybe what you might call a historic cohort, in looking at what's happened in HIV testing over at least 4 decades. And we're going to apply current evidence on blood-based biomarkers to determine which use cases might be appropriate for use of these. So here's the presentation outline. We're going to do this in 4 units. We'll have 3 poll questions to get your responses to as well. So thanks for participating. All right. First, we're going to talk about blood-based biomarkers for Alzheimer's disease pathology. There are 3 motivations that I had for doing this. One is that there have been 2 JAMA editorials, one in November and one in January, talking about how these tests apply in a primary care setting. There's been lots of press about blood-based biomarkers and what they might mean. And a friend who was being evaluated for a TIA ended up getting a blood-based biomarker for Alzheimer's disease, which confused that friend and also confused me. And so I know that there's several different ways in which we can do better. So here we go. So there's news in terms of FDA clearance, both in May of 2025 for Lumipulse being approved as a paired measure, looking at a ratio of p-tau217 and beta amyloid 142, and also FDA clearance for a single phosphorylated tau tau 181 to rule out AD in primary care settings. And we'll talk about this rule in, rule out sort of discussion in more depth. So here's a really important caveat, and both tests are approved for individuals exhibiting cognitive decline, which was not the case as best as my friend could tell, who had the threatened TIA, as well as I could tell in terms of knowing that friend pretty well and understanding that cognition, driving, financing, cooking, and all those sort of things. And so I think that this is really important in terms of what happens when we move from the group that it's developed in and applied into other groups and tests. So blood tests, as we know, are cost-effective, minimally invasive, highly accessible, and can help close the gaps and disparities and also improve access to care. Granted that some of these positive test results will have to be confirmed by a lumbar puncture or by a PET scan in order to confirm that the test that's being read by the by the blood-based biomarker is actually correct. And that's the standard of care before people might go to some of the early amyloid-targeted therapies for mild cognitive impairment that's AD or very early AD. All right, so one of our friends, Barak Gaster, who's been on the GMN sites a couple of times before and was at our most recent GMN summit, offered this in one of the JAMA editorials. He said the number one question he's been fielding from primary care colleagues is whether they should be ordering blood tests for Alzheimer's disease biomarkers for the patients. And what primary care providers are asking is, what does this? So we're going to get into that. So there's a lot of good information out there. If you haven't figured out how to go back and look at old GMN sites or recordings, Jim Law did this just in December, talking more in depth about the Taoists and the amyloidists and kind of how both of these, both amyloid and tau need to be present for disease, and talks about the use of blood-based biomarkers. Also, Chad Hales in November of 2024 also talked about diagnosing Alzheimer's disease with plasma tau. Is it a good idea? We're going to emphasize and amplify those concepts that they talked about in their Georgia MemoryNet Insights, both 2 months ago as well as a year and 3 months ago. And I also just wanted to point out, and maybe Emma, you could put this in the chat, where to go to find these past recordings, because they are a valuable source. And I had a good time reviewing them before I prepped this talk. The other thing, Suzanne Schindler, somebody that I met very recently, a clinical cognitive neurologist in the field, and she points out on our LinkedIn site in different ways to get more education on this topic. So obviously, I'm not going to be able to talk about everything that you'll need to know about blood-based biomarkers, but what did want to point out that there's a lot of recent information out there, and much of it good. And if you wanted to listen to your podcast while you're walking through a wheat field with headphones on, there are ways in which to do those as well. All right. So Heather Whitson and et al. In their JAMA editorial talked just early last month, talked about, all right, so what are some of the things that we should worry about with blood-based biomarkers in terms of their use in primary care and how that relates to the diagnosis of Alzheimer's disease? One is that patients and clinicians may not realize that there are multiple AD tests and they differ in their sensitivity and specificity. That's true. There's uneven access to the next confirmatory test. So if you can't get a lumbar puncture, or if you can't get an amyloid PET scan, those are things that are often required to follow up on a positive test that you might get on a blood-based biomarker, depending on your use case. So you still need to get through that. There are some harms of having Alzheimer's disease biomarkers in terms of people's existential wondering what that means and their planning. And had the pleasure of hearing one of the foremost lawyers in the field talk about, kind of what this means with regards to health insurance, long-term care coverage, and whether or not this is discoverable when you go for life insurance. And so there are some consequences of having a test and certainly having a positive result. But I wanted to focus on the last part of Dr. Whitson's Dr. Whitson's and partners editorial, is that the use of these tests in ways that the sensitivity and specificity might be changed is a really important way to recognize and realize this. And so since we are early in the review of these types of concepts, I wanted to just look at some historic use cases, but also want to do something that I've been doing for my board review, which is going over sensitivity, specificity, and positive predictive values, and how they're interrelated and changed based upon, and some of those are based upon the differences in the population that you're testing versus the test, how the test was derived in what population, and also the overall prevalence of the condition. So here we go. And we're going to let you see this, and then we're going to pop in our first poll. And so this is basically sensitivity as a screening test of A, B, C, or D. Let's see, answers coming in. Thanks so much for participating. Okay, we'll give folks a couple more seconds. And we'll go ahead and end the poll. And sensitivity is positivity in disease. So let's go ahead and review this. So the probability that a person with the disease tests positive is sensitivity, or a true positive rate. And so go ahead and close that poll. And so let's look at the A, B, C, and D questions here and look at the answers. Specificity is negative, true negative. Sensitivity is a true positive. And now we've got C and D as our negative predictive value and positive predictive value. So the proportion of true negatives among all negatives is negative predictive value. The probability that a person who tests positive truly has the disease is positive predictive value. So let's walk you through this in a couple of slides, and then we'll show you an online tool that you can use to go through this yourself. So in an epidemiologic table, you've got box A, box B, box C, box D. You set up the test results on this axis. The test result is positive at the top, negative at the bottom. The disease state has the disease on the left side and does not have the disease on the right side. So that makes this column your true positives. And this makes this box your true negatives. Your sensitivity is, hold on, I'm just going to move something around here. Your sensitivity is true positives over true positives and false negatives. So you're doing sensitivity here about people who have the disease. Specificity, you're reading up, it's true negatives divided by true negatives plus false positives. And the positive predictive value reads from right to left, true positives over all positives, and negative predictive value, true negatives over all negatives. So let's do 2 examples, and then we'll move on from this. A couple of things that change sensitivity. If you have different people that you're testing that were different from the population in which this was derived, and that somehow the part that's being measured, in this case plasma tau, is different from the amyloid PET standard, how those relate is kind of how you're deriving this sensitivity. It's often a gold standard at which it's tested against. So folks with CKD, folks on certain heart failure medications, even changes such as obesity might change blood biomarkers. And so also to note that brain amyloid occurs in diseases other than Alzheimer's disease. Okay, so let's look at an example of sensitivity, specificity, negative predictive value, and positive predictive value from some interesting test uses of HIV testing in the literature. So the first scenario is case A, where any person applying for a marriage license in the state of Illinois in the calendar year 1988 was required to have an HIV test performed and filed within the state. How would I know this? Because I was married in the state of Illinois in 1988, and both my wife and I were required to get an HIV test. Interestingly, 22% of the usual number, the number of people applying to get married in Illinois declined by 22% that year versus the prior year. So it was probably, we're going to go into this more, but it was a very interesting application of a mandatory HIV test. Case B is a more modern use of HIV testing, in that any patient receiving care in the Grady Hospital Emergency Department here in Atlanta, in Fulton and DeKalb counties, in 2024 will be provided with an HIV test, but an opportunity to opt out. And so what I'm going to do is I'm going to go through the sensitivity and specificity and use cases for both these scenarios and point out how the positive predictive value changes dramatically. Okay, so here are some details about 1988. The population is people trying to be married in the state of Illinois. The use case of why would you do this is to make sure that people know that they have HIV so they can avoid exposing their partner. The sensitivity of testing at that point in time is actually a series of 2 different tests cycled in ELISA followed by a Western blot to get your positives. Specificity 92%, so not as good as before. And what they found out in testing 70,846 people in this marriage license HIV testing is that they found 8 people with HIV that may or may not have been recognized before at a cost of $2.5 million. So probably not our best public health example. And as a matter of fact, the whole Illinois marriage license test was published in JAMA later the next year. So let's walk through this 1988 scenario, and we'll come back to the 2024 scenario in just a second. All right, so here's your relevant figures: sensitivity, specificity, and prevalence. And in that 2x2 table that I showed you earlier about sensitivity and specificity, positive, negative, predicted value, with any 3 items, you can generate the rest of the table. And so that's what we're going to do. So before we get there, give us your best guess as to what the positive predictive value is in this 1988 use case when the prevalence is 0.11% and the specificity and sensitivity and specificity are 98 and 98.7 and 92%. How many of the positive tests will go on to be confirmed as the presence of HIV? What's your best guess? We'll go ahead and end the poll and share the results. And we've got, oops, sorry. Go ahead. Kim, you probably did that. There we go. We got some sharing there. So some people between 0.14 and 1.4, 10 times as much. Some people weighing in at 4 and 11.4. So thanks, Kim. You can go ahead and stop sharing. All right, so let's fill this out and let's get to the right answer. So in general, to fill out this 2x2 table with the totals on the side and at the bottom, you start out with a hypothetical population. It doesn't matter what number you start with, but in general, when you start dealing with really low numbers like a prevalence of 0.11%, it's great to start out with 1 million, and you could just show how the numbers would be generated. So that gives you the prevalence of 110 people with disease, and then you just subtract from 1 million to get the number without disease. You take the sensitivity to take that 110 with disease to figure out how many had tested negative, which is 1. And then you use the specificity to generate the number of people in this 999 and 990 to generate that you would have 80 positive tests in people without disease, and you would have 919,999 who are true negatives. And so when you do that, you get a positive predictive value of 0.14% and a negative predictive value of practically 100%. But if you look at this, you've got 109 positive disease and positive test, and you've got 80,000 positive tests. So you can see how that positive predictive value becomes very low. So in general, a test positive predictive value is typically lower than its negative predictive value in a population where the disease isn't as common, such as the case with primary care patients and when you're testing in a sample that doesn't have a memory concern. So let's just very quickly just show you what the results would be for the same use case. You can tell that we went from sensitivity of 98.7 to 99 and specificity to 99%. And the prevalence is increased 100-fold, but it's still not that high. And so this is a public health testing strategy of people who are seen in the emergency room. And you have to go down here to look at, all right, so what's the reason for this? And the reason for this is that the therapies are much better than they were before. Multi-agent, single tablet, once daily, sometimes federally funded tablets for treatment of HIV, and then single once yearly PrEP injections for folks who in terms of trying to prevent the transmission. So very, very, very useful strategies. And when you look at this, the positive predictive value, just by moving that prevalence and changing the sensitivity and specificity ends up making the positive predictive value of 57.3%, which in this use case is an acceptable way to do that. So one of the things that you might want to go to is this link here, either by the QR code or by the information that I'll put in later at the chat. And maybe during question and answer, I can show you what this looks like live. You can basically adjust the prevalence and the sensitivity and specificity, and you can come up with the positive predictive value and the negative predictive value. As tests get better and as we test for populations that are more appropriate for testing, we'll increase the positive predictive value of these tests. And you can see how we did that by assuming a prevalence of amyloidosis in a population or a pretest probability of 20% or 0.2. Populations differ in terms of their likelihood of having cognitive impairment by their age. And the other thing to think about is that this is the initial, like all you know is the age and that they live in a US population. That will be influenced by information that you find out clinically, testing that you do in the office, so that you can get that pretest probability much higher than the 5.1 in terms of finding folks with early MCI and early AD. If you look at some of the test probabilities in terms of looking at sensitivity and specificity of one of the two threshold cutoff tests, you can see that the negative predictive value and the positive predictive value can be much better if you use it in the same way that they did in the derivation samples. So it reduces the need for LP biomarkers in many. There needs to be some confirmatory test before people get amyloid targeted therapies. But if you look back here, there's and right here in the middle where people have an indeterminate value, and you'll need to figure out what to do with some of those. All right. So final poll here. If you've been watching MemoryNet for a while, you've seen Dr. Hales give this talk about which patients should have a plasma tau test. And so we're going to use one of his quiz questions earlier. And he had used the exploding kittens no card on one of the following use cases. And do you know which one it was? Okay, great. Kim, go ahead and end the poll and share the results. So Dr. Hales applied the exploding kittens no card to use case number 3. Use case number 2 is the one that we often hear about most often, in that patients with cognitive symptoms and objective impairments. This is the way in which you can identify that these people with early and objective impairments end up having some amyloid pathology, might go on to confirmatory tests in order to be eligible for early treatment of MCI or AD with amyloid targeted therapy. Use case number 1 is one that's also out there in terms of this may be a useful test, a useful single test applied once to figure out if somebody who has advanced disease or might not otherwise be eligible, whether or not they have amyloid pathology. But it's probably use case number 3 that people said that this was the false choice or the no card choice more often. And that's that people who are worried about development of Alzheimer's disease due to family history or known status, or they'd just like to know what their amyloid pathology status is, may be a use case in the future, but is probably not a use case right now in terms of until some of the treatment of amyloid pathology to prevent the onset or incidence of Alzheimer's disease, until those tests read out. Right now, this is not a preventive test strategy. Home stretch here, we're going to go through a couple of things. Again, positive results may be challenging to deal with in terms of figuring out if you didn't have access to LP biomarkers, or you didn't have access to PET amyloid therapy, you still have that problem now. And negative test results are also possible. You saw how the negative predictive value was much higher, meaning fewer false negatives. And so also something to worry about as well. So one of the takeaway messages that I have based upon looking at a whole nother field to figure out what you do with some of these testing is making sure that you're dealing with a population that matches the test population that was used to derive the test. And these are folks with memory loss. And to figure out, kind of what you do with the results it can be very challenging. If you end up choosing a different use case where the prevalence of amyloid pathology is likely to be very low, it's likely that you'll be dealing with a high number of false positives relative to true positives. So these are the things that we said that we would go over today. We talked about interpreting blood-based biomarker tests in Alzheimer's disease pathology by going over sensitivity, specificity, positive and negative predictive values. We talked about a use case of HIV testing, one that was very public health useful, and one that ended up wasting a lot of money and finding 8 people out of 70,000 tested, and trying to look at how we might best use these tests in the future. I'll go ahead and stop. Oh, wait, let's see. This is the next poll. Just thanks for letting us know kind of who's in the audience. I appreciate that because that allows us to tailor our education. So we'll leave that up for a second. Thanks in advance for filling that out. And Kim, as I go ahead, you can go ahead and stop the poll and share the results. Dr. Loring is coming up next month. Dr. Loring holds the record for online views on YouTube with 1.5 thousand. So he has 1,500 people who looked at his very first Georgia MemoryNet Insights. And so hope you'll join us next month for that. Put in some information here about how to go ahead and get your CME. And we'll go ahead and start looking at the chat and or Q&A. All right. And thanks so much.